Hello, everyone. I am Dr. Jennifer M. Jones. Welcome to my presentation today. We will be discussing psychotropic medication use during breastfeeding, antidepressants, anxiolytics, antipsychotics, and mood stabilizers. Let's get started. There are practitioners on either side of the discussion, some who advocate for the use of psychotropic medications during pregnancy and breastfeeding, and those who are against it. Even with these two sides of the house, there's a general consensus that medication can be beneficial to the mother, but there's uncharted territory in truly understanding how psychotropic medications affect the child long term. This can also be said for children whose mothers go untreated. Considering all, there are unknown effective alternatives to medication, and there is not enough research on how the changes associated with body weight and metabolism during pregnancy affects dosing. So the good news is there is a general consensus in the research community that mental health concerns such as prenatal depression and postpartum depression, notwithstanding other mental health conditions, that postpartum depression and perinatal depression are so widespread that there has been a focus on establishing treatment guidelines that direct practitioners towards providing the most informed care possible to expectant and new mothers. In all cases, breastfeeding is encouraged with the medication sertraline, for example, brand name Zoloft. It is the preferred medication with the least amount of side effects and presents at the most minimal amounts in breast milk with little to no effects on the newborn. The takeaway here is that you, as new OBGYN residents, you do not have to go at it alone. There are supports and resources that you can build your practice around to help you navigate the use of psychotropic medications with your expecting mothers or with those patients who want to become pregnant. So let's take a look at breastfeeding. The exposure of the infant to various medications is dependent on the rate of absorption into the maternal circulation, diffusion from maternal circulation to breast milk, and absorption of the medication in the infant. The breast milk concentration of medication is influenced by lactose, serum albumin, lysozyme, prolactin, calcium phosphates, and other minerals and enzymes, more than 30. The foremilk, which equates to the milk ejected during the first half of the feeding, has higher lipid content than the hind milk, which is the milk ejected during the second half of the feeding. The hind milk will have a higher concentration of lipid-soluble maternal psychotropic medications than the first half. Kidneys of newborns are immature, so psychotropic medications that are eliminated through the kidney may accumulate in the newborn. The blood-brain barrier of the infants is also immature, so lipid-soluble agents can move can be more concentrated in the cerebral spinal fluid. So you want to be mindful of that because it can be more concentrated in the cerebral spinal fluid than in the serum, and may have maybe higher in the infants for a given plasma concentration. So you want to be mindful of that and look at all aspects when you're taking the blood levels. A little fact about breastfeeding: the breasts are serotonin regulated glands. The breast's ability to secrete milk at the right time is closely related to the body's production and regulation of serotonin. So basically, taking psychotropic medications that have their effects on serotonin can affect or delay a mother's ability to produce breast milk, creating another barrier or stressor for the new mom. So you want to be very mindful of that when you're prescribing. You want to have that conversation with your patient as well, so that she's not surprised should this happen to her. So it is very important for mothers to breastfeed, and this is why it may cause some distress for a mother who is having difficulty or who may not be able to breastfeed their child. So breast milk is the primary source of nutrients, immunoglobulin defense, and growth promoting factors for newborns. Infants who were breastfed have a less risk of mortality and morbidity, with health benefits that go into early childhood, including decreased risk for asthma, inflammatory bowel disease, diabetes mellitus, and hematological cancers during infancy, and it lowers rates of obesity. In addition to the benefits of breastfeeding for the child, there are benefits for the mother, which is awesome. So, reduced risk of ovarian cancer and breast cancer, reduced postpartum weight retention, and reduced bleeding, to name a few. Breastfeeding also facilitates mother-infant attachment. So that bonding that occurs between the mother and infant, this can occur during breastfeeding. And it's extremely important for a healthy growth and for a healthy mental state. As we all know, children who don't attach to their mothers do have the possibility to attach to other caregivers to help them be more healthy in growth. But if we can get that bond going with the mother and the infant early, that'll help the child's mental state as the child grows. So let's take a little look at what effects some psychotropic medications can do to the newborn through transmission in the breast milk. As a note for future reference, of the medications least recommended was paroxetine, which presents in breast milk with more significant repercussions for the newborn. Valproic acid during pregnancy is also discouraged. There is a possibility for the mother to commit suicide, losing the fetus, future psychological issues for the unborn child, low birth weight, behavioral problems in the child, in addition to cognitive and motor problems, just to name a few. Valproic acid is a mood stabilizer used to treat bipolar disorder and seizures, and some practitioners will recommend paroxetine for use. Do your research and make the best recommendations for your particular patient. And that's with any medication. You want to make sure to do your research and have the best information available so that you can present that to your patient and your patient make the best decision for themselves. Okay, so let's talk a little bit about the biology of things. So let's take a look at what's going on biologically in pregnant women. On the hypothalamic pituitary adrenal axis, there are hormonal dysregulations and or abnormalities in this region, with further challenges related to the genetics and epigenetics of the patient that would make the patient more prone to developing signs and symptoms associated with reproductive mood disorders. There are varying stages of hormonal dysregulation that occurs in the body of a woman at different stages of fetal gestation, as well during and right after the birthing process. When considering major depressive disorder during pregnancy and postpartum depression after pregnancy, you as the practitioner will want to consider the fact that during a normal pregnancy process with no mental health challenges or someone who's struggling, there are increases in estrogen, progesterone, and plasma cortisol in the third trimester. So basically what I'm saying is there are changes in the body chemically that will affect the mental state, whether the patient has a mental health issue or not. This is just natural to giving birth to a child and being pregnant. After a normal childbirth, there are sharp declines in these hormones. For women who are predisposed to these disorders, there is a dysregulation in how these mothers respond to the chemical. So if I already have issues with my hormone balances, pregnancy compounds that situation, and right after birth the levels drop. And so even with a woman who does not have a mental health issue, these drops in hormonal levels can cause severe depression, as we know as postpartum depression, and extreme mood changes, just simply as a result of the changes in their biology based on having given birth. So, as I stated, how these mothers respond to the chemical changes and how their hormones interact with the hypothalamic pituitary adrenal axis. This will determine how they respond. And so the hypothalamic pituitary adrenal axis is made up of the hypothalamus, the pituitary gland, and the adrenal gland. This is important to know because these changes may be the determining factor of whether a mother will be prescribed psychotropic medications during breastfeeding, if not already medicated, or maintained or increases in medications if already medicated. So you want to pay very close attention to that. So as OBGYN residents, you may make the assumption that the first step that comes with helping your pregnant patients with mental health disorders is to start with a review of the patient's medication. And this may be the case if the patient is transferred to you while pregnant, but if this is a long-term patient, you want to start with pre-pregnancy planning. That includes education on what happens during breastfeeding when on psychotropic medications. What does pre-planning pregnancy look tongue twister there, try it. What does pre-pregnancy planning look like? Peter Piper picked a pepper. Just kidding. So let's try that again. What does pre-pregnancy planning look like? Early screening, education, and early evaluations as soon as possible. The recommendation is you want to start these discussions with any woman who is of childbearing age. For patients who wish to get pregnant and have existing mental health concerns, make a plan around what medication use will look like during pregnancy and after pregnancy. Discuss the various possibilities. Be proactive. You want to be proactive with your patient and kind of make a plan for all the possibilities that may occur during or after pregnancy. Note, you want to take a good history, and that includes past hospitalizations, past suicide attempts, past medications. You will want to really have a well thought out psychological profile for your patient. With those patients who do not have a current mental health condition, you will want to be sure to discuss the possibilities of depression during and post-pregnancy. Those things are really important for a woman to be able to prepare herself and her family and her husband or her mate in knowing how to progress through those things. And the more prepared you are, the better off the patient and the families will be in getting through those challenges should they arise. You want to be sure not to abruptly stop any psychotropic medication without a clear plan, as abruptly stopping can increase chances of the mother relapsing, which can lead to suicide, infanticide, and a myriad of challenges with the unborn child through adolescence. So this is really serious. We want to take this serious and beyond into adulthood. So this is a heavy matter. Medication usage by the mother can decrease cortisol levels in the fetus, which have been found to be elevated in the fetuses of untreated mothers. And as well, we all know how high cortisol levels are not good for the mother or the child. So basically what I'm saying is medicated mothers have a better chance of helping their unborn child get a healthy start. And mothers who are not medicated, who have mental health issues, who don't take medication, stop their medications, have a higher chance of increasing the unwanted hormones in the child. So the idea is that the benefits of maintaining a medication regimen for pregnant women outweighs the side effects. So today we said we would be discussing some very specific classes of medication and how they play into breastfeeding. And these classes of medications are antidepressants, anxiolytics, antipsychotics, and mood stabilizers. Now that we have discussed the foundation of our talk today, let's dig into those specific categories. And first, we want to take a look at antidepressants. And so we mentioned paroxetine, which is an SSRI, and the brand name is Paxil. We mentioned that earlier as the least recommended medication to be used with pregnant women. So it presents in the breast milk with significant repercussions for the newborn. Citrulline Zoloft is another name. It was recommended earlier for depression, and it falls into the antidepressant category. And it's also used to treat panic attacks, obsessive compulsive disorder, PTSD, social anxiety disorders, and severe forms of premenstrual dysphoric disorder, and is considered to be very safe for breastfeeding mothers. There is a reasonable conclusion that antidepressants can be used with noted restrictions, those medications that are not recommended to be used, that are indicated in the relevant research. Keep in mind that infant exposure to psychotropic medications should not be measured only by the amount of the medication that the mother is taking or that she ingests during breastfeeding, but should also be evaluated based on the exposure to the infant and the infant's capacity to metabolize the drug. Let's take a look at anxiolytics. They're used to treat anxiety, which is for generalized anxiety disorders, and social phobia. Medications in this class that should be avoided are tranquilizers, and medications that you want to be mindful of as it relates to increased doses are diazepam, alprazolam, and clonazepam, as they cause sedation and respiratory distress in newborns. Anxiolytics cause neonatal side effects, specifically sedation as well as dependence, with the possibility of the infant experiencing withdrawal symptoms. So you want to keep that in mind. As a result of they experience these withdrawal symptoms as a result of the infant ingesting the breast milk from their mother who is taking the anxiolytic medications. When treating anxiety, citrulline, another name Zoloft again, an antidepressant, is said to be the safest medication to prescribe for anxiety when a mother is breastfeeding. So basically, avoiding the anxiolytics if possible, and utilizing the appropriate antidepressant in its place to treat the anxiety disorder. So now let's take a look at antipsychotics used for the treatment of schizophrenia and bipolar disorder. So all antipsychotics pass into the breast milk, so that's good to note, but it is said to generally be in small amounts. The lowest being in the medications olanzapine and quetiapine. Antipsychotics can also be used to treat postpartum psychosis seen in mothers after having given birth. Remember, we talked earlier about mental health disorders that occur after birth as a result of some of the changes in the hormones that occur right after birth. The recommendations in this field is for the mother to continue antipsychotics if without it, the mother is likely to become unwell again. So keeping in mind the progression or the history of that particular patient, if they are extremely sick or extremely unwell as a result of decreasing or removing that medication, you really want to consider keeping that patient on the antipsychotics that they're taking. Keep in mind, if you want to prescribe aripiprazole, it can reduce the levels of the hormone prolactin. This can mean the patient will not be able to produce enough breast milk. And we mentioned that earlier, that prolactin is important. That the mother producing enough breast milk for the child is important. And when they can't, that in and of itself can cause distress, depression, or anxiety in the mother. Prescribing clonazepam is not recommended to breastfeeding mothers because it can cause agranulocytis, which is a serious problem affecting the white blood cell count and it can cause seizures. So we want to make sure to be mindful of that. Now let's take a look at mood stabilizers. They're useful for treatment of acute episodes of manic or depressive, and for the prevention or relapse of recurrence of symptoms. So we discussed mood stabilizers a bit when we mentioned valproic acid, which is used to treat bipolar disorder and seizures. As we mentioned before, valproic acid is not recommended for use in pregnant women. The medication presents in breast milk and may cause the mother to commit suicide, losing the fetus, future psychological issues for the unborn child, low birth weight, behavioral problems in the child, as well as cognitive or motor problems. In addition to neural tubal effects that affect the brain or spinal cord, specifically spinal bifida. Lithium treatment is not recommended, but if it is sustained during breastfeeding, you want to make sure to take the infant's serum lithium levels as well as their electrocardiogram, as well as doing a complete blood count. That is recommended for the infant as well as the mother. The general consensus is to switch medications when possible, reduce the dose where necessary, and only maintain these medications in severe cases. And always review the patient's particular history, their severity of symptoms, and medical circumstances prior to any changes. You do not want to throw the patient into a severe psychotic episode because of abruptly changing their medications or stopping anything. If continuing medications while breastfeeding, monitor the newborn. Evaluate the baby's baseline behavior, sleep, feeding, and alertness while on mood stabilizers for the mother. Dosing of the mother is recommended right after breastfeeding. If you want to continue the mood stabilizers, make sure to pay attention to when you're giving the mother the medication. So recommended right after breastfeeding and right before the newborn's longest sleep period. So the goal here is to give the medication time to be less potent in the mother's system for when she is ready to breastfeed the child. So in conclusion, breastfeeding or not, breastfeeding is not just about medications. Breastfeeding comes with a lack of sleep for the mother. So that in and of itself can increase the possibility of a mother relapsing. So be mindful that your patient may have feelings of guilt, shame, or sadness related to not being able to breastfeed if this is what she decides. Encourage her that her decision is the best decision for her and her body under the circumstances that have been given. Also remind the mother that they should not sleep in the same bed as their baby, as bed sharing increases the risk of sudden infant death syndrome. This has increased risk if the mother is taking sedating medications. And as we know, this is possible if psychotropic medication is continued. There's not enough information to say that a medication is 100% safe during pregnancy or during breastfeeding. You want to aid your patient in calculating the risk versus the benefits based on the most relevant evidence-based information available for any particular psychotropic medication being prescribed. And for their particular case and circumstances, you want to take a look at how often and how severe their particular episodes of illness have been, medications that have helped, the medications that have made no difference, or the medications that have caused side effects. How the patient or the fetus or the infant might be affected if the patient becomes unwell during pregnancy or after birth, and how psychotropic medications might affect the baby. As always, consult and collaborate. So this ends today's presentation. We will take a brief question and answer period. Please note, none of the information presented here today is new information. It is data that I gathered directly from my references identified on the reference page of the PowerPoint presentation. Again, I am Dr. Jennifer M. Jones. Thank you all for your attending today's presentation on psychotropic medication use during breastfeeding, antidepressants, anxiolytics, antipsychotics, and mood stabilizers. Everyone be well.